Good morning, everyone. Hope you've been enjoying the cold weather or surviving the cold weather, depending on what stage of life you are in. If you have small children like mine, they are enjoying it, and I'm trying to survive it with them. But everyone, welcome back to the Department of Medicine Grand Rounds. Today we are excited to have Dr. Kelley Williams. Dr. Williams received her undergraduate degree from St. Louis University and then her medical degree from Illinois College of Medicine at Rockford. After medical school, she then completed internal medicine residency at Virginia Commonwealth University, and then came here back to St. Louis and joined the fellowship in endocrinology, diabetes, and metabolism here at WashU. As a fellow, she was involved in several clinical trials and research projects. These studies focus on the use of therapies for hypercortisolism and acromegaly, post-operative management of patients following transsphenoidal pituitary surgery, and hypogonadism related to hypopituitarism. After completion of her fellowship in 2020, she joined WashU and is now an assistant professor in endocrinology. As faculty, she sees patients for a wide variety of disorders, including pituitary disease, type 1 diabetes, and special interests for transgender patients, working as a part of the multidisciplinary Transgender Center. Today, she'll be talking about recent advances in diabetes technology and treatment of patients living with diabetes. Please help me welcome Dr. Williams.
Hi, good morning. Thank you everyone for braving the cool weather this morning to be here. For those who don't know me, I'm Kelley Williams, and I'm really excited to be here today to talk about one of my favorite topics in endocrinology, which is diabetes technology. I do not have any disclosures, but I'll probably talk a little bit here and there about some off-label uses of insulin, CGM, and insulin pumps. So I know we are all really well aware of the rising prevalence of diabetes in the United States, but I always think it's fun to start with some stats to set the stage, kind of show how important this topic is. So this was the last data I could find from the CDC in 2021. And at this year, 38.4 million people had diabetes. So that was close to 12% of the total population. So that was for all ages. Of that, 38.1 million were adults, so almost 15% of the adult population in the United States. 2 million of those had type 1 diabetes. Of the patients with diabetes, about 30% are treated with insulin. There have been 1.2 million new cases of diabetes each year, and almost 100 million adults with prediabetes. Then if you look to the figure to the right, this is showing the rates of diagnosed diabetes by race and ethnic background, so kind of showing the overrepresentation of the prevalence of diabetes from some of the minority groups. So a prevalence rate of almost 14% for American Indian or Alaska Native individuals, 12% for non-Hispanic Black, close to 12% for Hispanic, 9% for Asian American, and close to 7% for non-Hispanic white patients. Also, the rising healthcare, is that the right? Yeah, so the rising healthcare cost is also a growing challenge. So this was the last economic report from the ADA, so it was in 2023, and the total annual cost of diabetes in the United States was $412 billion. $306 billion were for direct medical cost, and then the rest were for direct cost. So this could be things like lost productivity at work, unemployment from chronic disability, premature mortality. And then after adjusting the population for age and sex differences, the average medical expenditure for people with diabetes was more than 2.5 times higher than the expenditure for people without diabetes. And then despite having a lower prevalence rate, women with diabetes spent more on average than men, and Black Americans paid the most in direct healthcare expenditures. Diabetes is really hard. We're giving patients very complex regimens. We might be asking them to inject different types of insulin multiple times a day, having them take pills once a day, twice a day with food, not with food, maybe adding in a once-a-week injection. This is really hard for patients, and it also comes with variable side effects. And financially, this can be really cumbersome for patients, even if they have good insurance. Hypoglycemia can be really scary for our patients on insulin, and it can deter them from strictly adhering to their regimen. I have had patients, if they have one severe hypoglycemia, they may never want their blood sugar under 150 again. lifestyle changes are really hard. Most of us aren't really well equipped at even counseling our patients on diet and exercise, and changing our behaviors. It's very difficult. And then patients with diabetes are 2 to 3 more times likely to experience depression. And there is different stats out there for type 1 diabetes, increased anxiety, and they're more likely to have disordered eating. And then, of course, we know there's all kinds of healthcare limitations in terms of access and resource for our patients. Now I'll get into continuous glucose monitors, or CGMs. And I guess a fun stat is for patients with type 1 diabetes, back in 2006, about 3% of patients were CGM. The last stat I could find was 2019, and close to 50%. So these use are increasing dramatically, and I'm sure now it would be much, much higher than that. The brands that are available to us are listed up here. So in clinic, most of us are going to see the Freestyle Libre and the Dexcom. So these are the most typical ones that we'll see as standalone CGMs in people who are on injectable insulin. So the Libre, the newest iteration, is the Freestyle Libre 3 Plus, and then we have the Dexcom G6, G7. The Eversense is an implantable CGM. So it's a small little rod that goes into the arm, kind of like a Nexplanon, and it can stay there for a full year before it needs to be replaced. The cool thing about this is the transmitter can go on top of it, so it's easily removed for swimmers, athletes, people who want to take it on and off. It does not yet work with any of the insulin pumps, so it's not as widely used at this time. And then we have the Medtronic CGM as well. So the newest is the Guardian 4. That works with the Medtronic pump. So this one you won't see as a standalone in someone who's on just insulin injection. So by and far, it's the Freestyle and the Dexcom. And all of the CGMs now are pretty much real time, so we get continuous measurements and not the intermittent scan. So that was the oldest rendition of the Libre. Coverage is important to think about when we're wanting to prescribe these for our patients. So type 1 diabetes is really nice. Now, pretty much everyone can get this covered if you have type 1 diabetes. And type 2, if you're on at least one type of insulin, they can probably get this covered. So for folks that you're seeing in clinic, if they have type 2 diabetes and they're even just on basal insulin, you could probably get a CGM covered. Gestational diabetes usually has coverage if they're using insulin. And then Medicare. So Medicare for type 1 and type 2 diabetes, again, if you're on one type of insulin, even if it's basal, you can get the CGM covered. Medicaid will vary based on the state, and actually this one, Missouri is a little bit more lenient than Illinois, where again, you just need to be on one type of insulin a day, have had hypoglycemia, or are visually impaired. If your patients are in Illinois, they still have to have mealtime insulin prescribed, which is a little bit of a bummer, and they have to pick it up on the dot every month. If they're not filling it every month, they will not be able to get their CGM. So this is some data from the Type 1 Diabetes Exchange Registry. And so this registry is a research initiative that's really designed to collect and analyze data to help improve the lives of people with type 1 diabetes, and they work with multiple centers across the United States. So at this time that this study was published, the registry had almost 18,000 patients with type 1 diabetes, and they were looking at these patients who had a clinic visit between 2014 and 2015. We had at our center here, I think, about 500 patients in the registry, which is pretty cool. And what this is looking at, so patients who were on injection alone, patients who were on an insulin pump, and then patients who are on injections plus a CGM, and then a pump plus a CGM. And what you can see is, despite the insulin delivery, if you put a CGM on someone, their A1C is going to go down. And this has been shown over and over again in many different studies, and it's pretty consistent that, again, you just throw a CGM on someone, their A1C is going to reduce almost as much as what some of the medications are, so a half a A1C percentage point. I'm going to talk about a couple of the pivotal studies, again, just to kind of set the stage for these technology. So the SWITCH study was one of the first studies looking at CGM, and it was in 2012. So it was a randomized multi-center crossover study. It was using an older sensor called the Enlight sensor and the Medtronic pump. And what you can see, is when you put a CGM on someone, the A1C is going to go down. You take the CGM off, the A1C is going to go back up. And that was the same for both groups. And these data have been consistent across many studies, whether the person has type 1 diabetes, type 2 diabetes, if they're on a pump, if they're on MDI, if they're just on basal insulin. So again, putting the CGM on someone, your A1C is going to go down, again, in both groups. One of the other early pivotal studies was the GOLD study. And so this one's also looking at hypoglycemia. So this was an open label, another crossover RCT, in many clinics in Sweden around 2014 to 2016. So there were 160 individuals with type 1 diabetes. They were all on MDI, and they were put on the Dexcom G4, so an older rendition of the Dexcom. And the two graphs I put up here were level 1 and level 2 hypoglycemia. And what you can see is that when you put the CGM on someone, the percentage of time in hypoglycemia goes down. You take it off, it goes back up. And that was the same for level 1 and level 2 hypoglycemia. So not only are we reducing A1C, this is not coming at the cost of increased hypoglycemia. We're having less hypoglycemia as well. Again, this is seen in many, many studies. There are some challenges with CGM, and we'll have patients come in and talk about these a lot. And one will be patients are like, well, it's not accurate. I'll check a finger stick. It's different than what my CGM says. I don't think it's working. So it's important for us to remember and to educate our patients on the difference between CGM and finger sticks. So CGM is taking the fluid under the skin. And so that's in the interstitial fluid where the finger stick is the blood, of course. So glucose enters the blood, then it goes into the interstitial fluid. So you're always going to have this lag, usually of about 5 to 15 minutes. And that can be more prominent if there's rapid shifts in glucose. So blood is a more immediate read, so better real-time measurement. However, if things are pretty stable and there's not rapid fluctuations, they do tend to correlate quite well. So I think this is important to talk about. Also, people will have issues with skin, irritation, their sensors falling off. It can be really frustrating. So companies are really good at sending patients overlay patches, so I encourage people to check those with the companies. There are also a lot of skin barriers and a lot of different tips and tricks that are out there to investigate if this is an issue. And then interfering substances is good for us to all be aware of as well. So for example, with the Dexcom G6 and G7, if a patient is taking more than 4 grams of Tylenol a day, which probably they aren't, but if they were, that can cause a false high reading. High doses of vitamin C can cause false highs with the Libres, hydroxyurea, so there's various ones out there, so good to think about. And interestingly, so finger sticks is using the same enzyme, glucose oxidase, so there also are interfering substances with our finger sticks. High doses of Tylenol, dopamine, furosemide, so things that we may see in the hospital could interfere with our finger sticks, so just to keep in mind. Time and range is kind of the new thing out there. So the international consensus guidelines came out in 2019. That's telling us if our patients have the CGM, we need to be using this data in conjunction with the A1C to really assess their glycemic control and to make adjustments to their regimen. So for type 1 and type 2 diabetes, we really wanted patients to be at least 70% of the time in range. We consider that about 70 to 180 is the range we're looking for. If someone is older, they're high risk, a lot of comorbidities, we may say, okay, at least 50% in range. And then diabetes has its own kind of set of guidelines. But these in 2019 were really before a lot of the improvements in the automated insulin delivery system. So 4% of hypoglycemia is about an hour. So each percentage point is about 14.4 or 15 minutes, let's say. So the older school of thought was, okay, we can tolerate an hour of low blood sugar. But again, with the improvement in the systems we have, we think we can do better than this. We can have higher time in range and less hypoglycemia. And this thought of time in range has also been setting new metrics for clinical trials. So again, using this maybe more or in conjunction with A1C. So lots of patients are wearing CGMs. They're coming into the hospital, and we need to know what we should do with these devices. Diabetes, the ADA came out with their standards of care, and they do have a chapter on what to do with these devices when people come into the hospital. So with CGM, we say we should continue them as long as the patient's awake or able to manage their device. But we do still need to confirm point of care finger sticks to make any insulin treatment decisions or to assess their hypoglycemia. So this is because the FDA still has not approved CGM for hospital use as standalone for treatment options. There's just a high MARD in the hospital, so CGM is less likely to be accurate in these settings because there's lots of dynamics and shifts in the hospital. And during COVID, they did approve the use of CGM for treatment decisions just to limit the interaction with providers and patients. And it was found to be helpful, so this could change at some point. More studies are looking into this, but it is a little bit of a difficult one. And then pretty much the same thing with insulin pumps or automated insulin delivery systems. We have patients continue these in the hospital, again, if they're awake and alert and it's appropriate, but we still need to check their finger sticks. All contingent, of course, on hospital policies, which we have policy here, and we allow our patients to continue the pump. And honestly, if they're awake and alert, patients tend to do much better than we do at managing their diabetes. So this is a study that demonstrates the usefulness of CGM in the hospital. So this was from Diabetes Care in 2020. It was a multi-center, non-inferiority open-label RCT at Grady, Emory, and University of Maryland Medical Center. About 185 patients with type 1 and type 2 diabetes on MDI. So really looking at point of care versus CGM, and that was a Dexcom G6. And there were no significant differences in time in range, daily glucose, or time below range. What we did see in this study was for recurrent events. So for patients who are having recurrent hypoglycemia or recurrent nocturnal hypoglycemia, they did have less events in the CGM group. So what this is telling us is this is a good safety measure for patients in the hospital. And there was a trend in the study towards improvement in hyperglycemia and time below range. It just wasn't statistically significant. Some studies are looking at this and showing some significance, but again, not really confirmed at this time. I wanted to talk a little bit about biohacking because we're seeing a lot of patients come in without diabetes wanting to wear CGM. And there's a lot of proposed pros out there of why patients want to do this. So we are going to enhance dietary awareness. So it's giving you real-time data. So maybe patients can understand how different foods are affecting their blood sugar, maybe improving dietary choices, maybe improving metabolic health. I put up an article from Reuters where Olympic athletes have been using these to enhance their performance. So maybe improving energy intake and expenditure. And then, yes, maybe detecting early dysregulation. So if people are noticing higher sugars, maybe we can catch diabetes or prediabetes earlier. I put up the two systems that are out right now. So these are not prescription. You can get them from a subscription service. And Dexcom has the Stelo. This is approved for type 2 diabetes. It does not have low alerts, so we tend not to use them if people are on insulin. And the other one that just came out was from Abbott. So this is the maker of Freestyle Libre, and it's called the Lingo. And so I put up their website, which is really enticing. Feel better, manage your weight, manage your cravings, improve metabolic health, all of these things. So this is about, at least I didn't look at the Lingo, but for the Stelo, it's about $89 a month for their subscription service. I assume the Lingo is about the same. So you can't really go to the pharmacy and get them over the counter. You do have to use their service. Okay, what are the challenges of this? So overall, I will just say there's a lack of research showing CGM improves health of these individuals without diabetes. And here are some of the possible challenges. So patients may interpret normal or mild fluctuations, which can lead to unnecessary concern or restricting diet. And then maybe even more than that, leading to disordered eating patterns. And then what are the norms of these ranges in people without diabetes? So I put up two studies. I know the top graph, it's really kind of hard to understand this, but this one came out from the JCEM last year. And what's cool about this study, it was using the grandchildren of the original Framingham study, and looking at people in this group who had diabetes, prediabetes, and normal glycemia, and they wore the Dexcom G7 for a week. So this kind of tight time and range, 70 to 140, is being proposed and growing interest to help our patients achieve better control. But in this study, for the patients who were normoglycemic, they had over 3 hours a day in this above 140 range, so maybe above this optimal range, and then about 15 minutes a day above 180. And then, of course, much higher for people with prediabetes and diabetes. The bottom study, Viral Shaw did this, and this was published in 2019, and then it's looking at what about hypoglycemia. So in this, over 35, or about 35% of the participants spent more than 2%, so over 30 minutes a day, less than 70, but really pretty infrequently less than 54. So probably supporting some of the consensus that 54 is probably a more clinical, meaningful cut point for hypoglycemia than 70. So if someone's, in the 60s, it's probably fine, it's probably normal, but patients may get really anxious about this. So I guess the end result is, it's really hard to say patients, are benefiting from this at this time. There's just lack of data and research into this. So now I'll switch into insulin pumps and automated insulin delivery, or AID systems. And I think looking through the history is pretty fun. So in 1963, Dr. Kaddish of LA designed this backpack insulin. And it wasn't until 1976 that Dean Kamen, who was an engineer, developed this more wearable form of an insulin pump called the auto syringe. He sold that to market, and he actually founded DECA, which is still an ongoing R&D company who's invested in creating medical innovations. And it wasn't then until the 1990s we started creating more advances into the medical technology field. So, and these kind of initial pumps really had a lack of safety standards to ensure safe insulin delivery. They weren't user-friendly, and some of the models you actually had to use a screwdriver to adjust the insulin. So pretty cool where we are now. Automated insulin delivery systems are a broad category of automated insulin that's using a CGM, an algorithm, and an insulin pump. So you'll hear me say AID quite a bit. And then hybrid closed loop, HCL, is another term that you'll hear thrown out there. And so an HCL, or hybrid closed loop, is a type of AID system where the delivery is partially automated, but you still need user input. The guidelines for ADA and insulin pump therapy have changed a lot in the last couple of years, and I think this will show the importance of this technology and the outcome data that we've talked about and we'll talk about. So if you look to even last year, so for type 1 diabetes, the ADA said we should offer these systems to people with type 1 diabetes if they can use them, if they're capable. And now in 2025, the guidelines say these should be the preferred insulin delivery to improve outcomes and reduce hypoglycemia. And really the same thing for type 2 diabetes. Last year it was they should be offered if they can use the device. And then 2025 is, again, we should be offering these to improve control. And then even looking back to 2018, so not that long ago, the ADA said, oh, it's probably an option if they're not at control. 2016, it was, well, if they're, yes, not at control at MDI. So really even in the past 10 years, it's gone from, oh, maybe kind of we should, until, yes, these are the best systems that we should be using. These are the 4 AID systems that we have in the United States right now. So the Omnipod 5, and I guess I might use some brand names because there aren't generics, but the Omnipod 5 is the patch pump. A lot of people like these who are young and active. They could move it around, it's mobile. It works with the Dexcom. The tandem pump, the T-Slim, it is a tubed pump. They have a smaller version now that is a little bit more mobile. It works with the Dexcom or the Freestyle Libre 2. Medtronic has the MiniMed, and it works with its own sensor. And then the newest one that we have out is from Beta Bionics, so the iLet Bionic Pancreas, and it works with Dexcom, and we'll talk a little bit more about these systems as we go through. For the non-endocrinologists in the room, just as a reminder that for most of these systems, not all of them, when patients come in, we are putting in settings and adjusting them. So we'll tell the pump what we want someone's carb ratio to be, their correction factor, their target. Depending on the pump, the basal rates may assist, but we are doing a lot of input in our office. Breakthrough Type 1 Diabetes, or it was formerly known as the JDRF, created this framework for the artificial pancreas development. And I think it's kind of interesting just to go through where we've been in the last few years. So starting with step 1. So this is the slam on the brake step. So we want the insulin pump to shut off if a patient is not responding to a low alarm or if there's hypoglycemia. So this first came out in some of the older Medtronic technologies, and so you can see as the glucose starts to go down, the user or the patient will get an alert. If the patient does not respond to this, or if the glucose is frankly low, the insulin will suspend, they'll get another alert until the glucose returns to normal above the threshold, and then it will resume. So first step is safety. We want to prevent bad outcomes of hypoglycemia, so we slam on the brakes. What's better than this if we can slow down a little bit? So we want to predict hypoglycemia, reduce basal, and try to prevent this from happening. So this was the tandem insulin pump technology, and it's called the predictive low glucose suspend system. So what it is doing, it's looking at the current glucose and CGM values. It's trying to predict the rate of fall, and if it's predicting that the glucose is going to be below the threshold, which is usually 55 to 70 within the next 20 to 30 minutes, it's going to start slowing down and suspending insulin to try to prevent that trajectory down. Then as the glucose stabilizes or rises, the basal will increase. So it can suspend for a max of 2 hours to try to help prevent this hypoglycemia. So again, making pumps even safer. Okay, great, we can stop, we can slow down, but now what about hyperglycemia? So this is an example of the Smart Adjust technology with Omnipod. So it does the same thing. If glucose is going low, it will slow or suspend. But now when glucose starts to rise, we want to increase that basal to try to prevent hyperglycemia. So this is thought of kind of fine-tuning the cruise control. And this Smart Adjust system with Omnipod will adjust the insulin delivery every 5 minutes, again, to try to get the glucose to target. And then it has a smart bolus calculator where if someone's going to put in their carbs to give a bolus, it will use the trends of the glucose to try to fine-tune that bolus, to either give a little bit more or take away some if we're already low. Okay, step 4, we want to do a little bit more with this closed loop system. So we want to add in a little bit of bolusing as well. So this is where the corrective doses or these auto boluses come into this system. This is the newer kind of upgrade technology of the Medtronic pump. So the gray line is the glucose. The dotted dash horizontally is what we want the target glucose to be. The pink lines are what we've already talked about. This is the basal rate increasing when we're high, decreasing, suspending when we're low, but then we're adding in those blue. So whenever the glucose is high, we can try to add a little bit more, give a little bit of higher boluses every 5 minutes to get back down to target. And they have a meal detection technology. So if the system is detecting kind of a rapid rise, so predicting that this is a meal, it is going to give stronger boluses to try to bring the glucose down faster. And you can see the gray line, the trajectory of using this meal detection forgiveness versus if the pump did not. So again, we're kind of fine-tuning things with our basal rates. This slide is a lot, and this is really just to demonstrate what we get as providers when people come in with this technology. This is a report from the Tandem system, so showing that when patients are on these, we don't just let them go and have fun. We really interrogate and use a lot of this, and we get so much information. So we can see their glucose information, their time in range. We can see what they're doing with their insulin. Are they bolusing? Are they relying just on auto boluses? And then we get a day-by-day report, which we can see everything we're doing, that the patient is doing, and what their behaviors are, for better or for worse. So we can see, and it's all overlaid with the glucose. We can see the glucose and all the insulin delivery. So the bottom bars, we can see what the basal is doing. We can see when it's suspending, when it's red. The little apples are when the patient is bolusing. The diamonds are when the pump is giving correction. And then we see things like sleep mode, exercise mode. So basically, we can see what patients are doing all the time and help correct some of the behaviors. Okay, great. This has been wonderful so far, but wait, we can make this even better for our patients. We can take out the need to carb count and enter carbs and just have patients kind of go about their lives. So this is the newest system, the Beta Bionics iLet Bionic Pancreas. So right now it's just insulin. And the patient does not have to carb count. They just have to announce a meal. So they will say it's their breakfast, lunch, dinner, and either it's their kind of normal size meal, more or less. And so it just takes a lot of the work out for the patient. One thing that providers have been a little nervous about at first is really we can't do anything. We put in their weight and then we send them on their way, and that's really all the control that we have. So this is really cool for patients. Dr. McGill liked to call this the princess pump for patients who really just kind of want to, throw it on and go about their day. So it's really cool, and I have a nice case at the end to demonstrate how this can be life-changing for people. Just a very short time about insulin pens, just because I feel like this crowd could utilize them. So smart pens, and I'm going to talk about the InPen. This is the most common one. It's from Medtronic. It connects, so it's a smart pen that connects to the smartphone via Bluetooth to help people give their insulin. So it's a phone app, and again, we can put the settings in. We can put different carb ratios at different types of the day, correction factors, their target, and people can just enter, whatever their carbs are. It will give them, it'll do all the calculations and tell them what to bolus, and then it logs it for them in this app. And then selfishly, we get reports just like a pump and can see everything the patient's doing. And it can also set reminders for patients too to give insulin if someone is a little bit forgetful. Pregnancy is a whole other lecture, and it's really complicated. The newer CGMs and pump technologies, again, they have great accuracy, they have great features, but most of these are not studied in pregnancy. And so we have this big gap in knowledge of whether or not these systems are beneficial for this population. So really, we're trying to continue to evolve and learn how to incorporate this into pregnancy. The challenge is all the systems we've talked about, the targets that we get don't quite meet pregnancy standards in terms of the target of, let's say, 95 for fasting. The Medtronic has the tightest target right now of 100, so we don't always quite meet the pregnancy standards. The challenge is a lot of these people are on the systems before pregnancy. They're doing great, and they usually just do better when you stay on them instead of trying to take them off. But again, just kind of still a gap in knowledge. So we've all learned little tips and tricks to try to work the system as best as possible to get as best control. So there are some considerations for using this technology also in the peri-op or intra-op period. So a couple of our providers here worked really hard on this paper, Dr. Cruz, Dr. McKee, and Dr. McGill, along with others, looking at what to do with these systems in this period. So CGMs, we already sort of talked about. We still need to do point of care for accuracy. So we can use the CGMs, but also if you think about in this period, that data is going to the person's phone, family, endocrinologist. The OR providers aren't going to be able to see this information anyway. However, if possible, we should leave them on the patient because insurance will only give people a certain amount for a month. So if we take it off, throw it away, they may be out for the rest of their week. Kind of the exception is, of course, if it's in the way or if there's certain equipment being used in the OR, so electrocautery, fluoroscopy is a couple of them. There may be some interference, so as of right now, there's not enough data to say to keep them. We should probably take them off. Pumps have its own kind of prerequisites as well, whether we should keep them or take them off. The general consensus is if it's a short procedure, less than a couple hours, it's not super invasive, so we're not predicting a lot of glycemic disturbances, if it's not going to be in the way of the surgery, and if the patient will be able to wake up fairly quickly after to manage their pump, usually we keep them on. Again, if there's not MRIs in the procedure or fluoroscopy or things like that. If the surgery is more invasive, if it's going to take a long time and there's predicted to be a lot of disturbances, if there's MRI, if the person is going to be sedated for a while after, it's usually best in standard practice just to go ahead and do sub-Q insulin to take them off the pump or IV insulin. So more guidelines in this paper if you all want to check it out. Now to talk a little bit about outcomes, and maybe this is the money slide. So reduction in A1C and increased time in range has been found using these AID systems. They also have a decrease in hypoglycemia. So again, we're improving A1C without increasing hypoglycemia. This has been shown to reduce acute events like DKA and hypoglycemia emergencies. So I couldn't find any great papers looking at improvements of long-term complications, probably because we need more time to kind of show these, but I could postulate that we're going to see this if we're improving A1C and reducing hypoglycemia. Just like the CGMs, there's a couple, pivotal standard trials that are out there that are proving this to people. So I picked to talk about the International Diabetes Closed Loop Trial. So this was the pivotal trial looking at the tandem insulin pump using that Control-IQ technology. And it was a RCT with patients either assigned to this hybrid closed loop system or a standard insulin pump that just had the basal shutoff or MDI. It was multi-center, international, had a very diverse population, had children and adults with varied A1Cs, and it lasted about 6 months. So what this showed, kind of in our quadrants here, if you look up at A, it's going to show an improvement of time and range. So the hybrid closed loop group spent about 71% of the time within the target range, so again, 70 to 180, versus 59% in the standard group, which is over 2.5 hours of the day more in range. It had an improvement in A1C, so I guess here's the graph. So the average A1C in the hybrid closed loop group was about 7.4%. At the end of the study, it was 6.9%, so that is a pretty good improvement, and there was no change in the standard group. And then, like we've talked about with the hypoglycemia, there was no increase of hypoglycemia, even though we've improved control. And actually, time spent below range was reduced. And just of note, too, that they also looked at user experience in this study, and patients were highly satisfied with using the hybrid closed loop, and it was improved versus the standard group. And this was seen in the Medtronic studies, the Omnipod studies, so this has been shown, these similar data over and over again. What about quality of life? This is also important. We talked about diabetes is really hard, and we give them a lot of work. Does this increase the burden of patients? And some studies are looking at this, and really the answer is probably no. People are noting decreased burden, less fear of hypoglycemia, improved sleep quality, and satisfaction. So this was a study, it was a 2-year RCT, type 1 diabetes who were adults, looking at folks who were just on MDI and finger sticks, and then putting them on a 780 Medtronic, a closed loop system. So 37 people completed this trial over 3 months. And then the primary endpoint was time in range, but they also did have some secondary endpoints, and one was using this validated quality of life survey that a lot of diabetes studies use this particular survey. And what you can see after 3 months, people said they felt better, working was easier, they could eat as they would like, and they just felt like they could do normal things. They extended this study out, so 18 people continued on for a full year. And what's important to know about this, at the 6-month mark, they changed from the Medtronic 3 to 4. And what's important about this is the 3 you still had to calibrate with a finger stick twice a day, the 4 you didn't. So at the end of this, the entire quality of life survey was statistically significant, that people felt their life was better on this system. And that showed true, even changing from a pump who had the auto suspension versus a hybrid closed loop. So changing people even just from a standard pump to these systems showed the hypoglycemia fear survey was improved, so less fear of low blood sugars. They felt their regimen distress was improved. Their interpersonal stress was improved as well. What I'm really excited about is the emerging technology that's coming out, so I wanted to spend a couple slides on this. So this hopefully will be coming out this spring. So this is the twist pump, and it's going to be working with the tide pool loop system. So for the endocrinologists here, this was a DIY system that a lot of patients were doing and hacking before the hybrid closed loop pumps. So it's a pretty cool algorithm. It's probably going to work with the Freestyle Libre 3. It's not been announced yet that I know of. And it is, what's very cool about this is it's going to allow for tighter targets, so people can get tighter control, which will play back to the pregnancy, where I think this could be a good pump to get those better targets. People will still have to enter their carbs, so it's still a hybrid closed loop system. But because it's small, it's going to be more mobile as well. So maybe giving people a little bit more freedom as opposed to kind of their bigger pumps that dangle. I just learned about this actually this past week. So the CAM APS FX algorithm has been approved by the FDA to use in pregnancy. So this is an adaptive advanced closed loop system where you can get the target down to 80, which is the tightest that's out there. This is up and running and going in Europe, going with pregnant women in Europe for a couple of years now. So they have good data to support the use. And it works with something called the MyLife pump, which is not FDA approved, but it is undergoing review right now. And I read that maybe sometime late 2025, this could be a system available in the United States. It is a bit of a bigger pump and we'll have the tubing. And then for our last step, step 6, when we're talking about this framework, what about a fully automated multi-hormonal closed loop system? And so this is the iLet bi-hormonal system that we're excited about for the future, where we're going to have glucagon, insulin, kind of simultaneously delivering hormone to really fine-tune that control. The last little bit that I wanted to talk about were just some various challenges and barriers to these AID systems. And there are a lot of health disparity challenges. So some of the system challenges that we face are socioeconomic, racial, ethnic barriers to accessing this technology. Of course, we all know how challenging it is to get insurance coverage and reimbursement. There are some user challenges, just tech literacy of our patients, device fatigue, making sure they know what to do if their pump malfunctions, making sure they have insulin to give if that happens. And despite all of the great benefits of technology that we have discussed so far, there are still significant inequities in tech use by race, ethnic, and socioeconomic status. And I put some of the studies up here that support my statements. And when compared to non-Hispanic white individuals, non-Hispanic Black, Hispanic individuals, and Hispanic individuals use tech less frequently. Black patients were less likely to have had discussions with the diabetes care team about technology and were less likely to receive prescriptions for these technologies. And then individuals from high socioeconomic status and non-Hispanic white groups are more likely to be started on insulin pumps in the first year of their diagnosis compared to other groups and those of lower economic status. So, and these disparities persisted after adjusting other social determinants of health, glycemic control, mental health, diabetes outcomes. And so really considering the benefits of this tech, these data highlight the need of a standard approach to discussing tech with our patients and incorporating it into their care. I mentioned the Type 1 Diabetes Exchange earlier, but again, this is a nonprofit organization, and their mission is to improve the outcomes of people with Type 1 diabetes. And they have a quality improvement collaboration with many centers across the US with a lot of patient data. And so they've created these quality improvement projects or interventions to be designed to work on improving equity for patients. So like I mentioned in the last slide, their data has also found that people of color are less likely to be prescribed CGM or pump, less likely to receive education, and are more likely to be hospitalized for hypoglycemia and develop complications. So again, this population should be using these systems. So this fishbone here is part of their equity change package that starts to look at what are some of the barriers, what can we do? And just to highlight a few of these, so of course insurance can be a problem, denial. Using DME companies for pumps are really cumbersome for patients. There can be provider bias, education staff bias, language barriers, limitations, people not being able to get to their appointments because of their job, issues just with trust in the healthcare system. So lots of barriers, right? So what can we do? So the Type 1 Diabetes Exchange has published a lot of really practical approaches to advance equity using multi-level interventions. So they have a lot of strategies to address these disparities, whether it's working on policy, community programs. They have training for providers, bias training, which I think is really interesting, among others. So this is just to highlight that they have a lot of resources and information for organization and practices to help work on this. And also whether it's just getting translator at appointments, getting handouts to different pump companies in different languages. And so if anyone's interested in this, this website, and I could give this to you as well, has a great care package that is for organizations to use to improve this. And actually last year they had their first equity conference at the ADA as well. I do have a case to talk about kind of within this regard. So this is a patient that when I saw her, she was 20, African American, and she was diagnosed with diabetes around the age of 6. She'd always been on MDI and finger sticks, and you can see her regimen. Pretty complicated. You're giving carb ratios, granted hers are the same all day right now. Her correction factors, what her target is, a pretty high dose of Lantus. And when I was seeing her, this was one of the statements in the chart, right? Long-standing history of poor, non-adherent diabetes control. She's had numerous DKA admissions and ER visits to various facilities. She does not take her insulin or test her glucose. And there's also a statement describing her interest in doing better, but she cannot maintain these habits. BMI was about 21, so maybe indicating this is a pretty hefty regimen. And she already had some complications of steatosis and elevated urine protein. When I was talking to her, she felt like she was having episodes many times a week of hypoglycemia. When she was hospitalized, she would need much less regimen. So again, this regimen's probably too much for her. And here are her A1Cs through time, so long-standing poor control. So the older school of thought with this tech was that patients needed to prove they could be on technology, that they are checking their blood sugars, they're motivated, they have some reasonable control before we put them on these systems. So one of the early visits, we put her on a Dexcom. Not great, right? But hey, A1C was estimated to be around 9.2, so improving from 15. So I think that's pretty successful. And then went ahead and just put her on a hybrid closed-loop pump. This was after a few months of being on the pump, and I think the results are outstanding. So estimated A1C is down to 7.3, time in range, not bad. And even more importantly, she has not been in DKA or been admitted since she's been on this pump. So maybe the older school of thought, yes, it's just terribly outdated. Managing the daily kind of life and health of diabetes is really hard, and they can face discrimination on kind of different avenues of their lives. So we need to be sure we're advocating for our patients with diabetes kind of at all levels. The ADA has published some evidence-based peer-reviewed statements on all of these topics just to help us advocate for our patients. So whether it's driving and diabetes, getting accommodations at work, school, making sure they're being managed appropriately in detention facilities. They write these so that way we have things to back us up when we try to advocate for our patients. So I just implore you all to look at these if you ever need statements to help you. And then my last real-world application that I was excited to talk about. So this is a 36-year-old man. He has type 3C diabetes, so recurrent pancreatitis and atrophy of his pancreas were the cause of his diabetes. Has been on insulin for many years. He has underlying Sturge-Weber. He's had intractable epilepsy. He has had an hemispherectomy, left-sided hemiparesis. He's been in a living facility for many years. He also has other health complications, osteoporosis, CKD, and he has been needing eye injections for his retinopathy and macular edema for many years. Occasionally needs tube feeds, but honestly, he just loves junk food. Lots of sugar, sweet, soda, all at the end of the night. He's always been on MDI and either managed by his mom or now the facility for the last several years. Finally started a Dexcom in 2022, but overall just very poor control, and it's really challenging just due to his appetite, dietary choices, and also living in a facility. Timing of insulin and following the regimen is really difficult. Partly because this is what I would give the facility, which is like very hard for anyone to follow. Give 6 units with breakfast, 15 if mom brings breakfast, 7 if he has a glucerna instead of breakfast. Do all of these, trying to really mimic a pancreas, right? So I can understand why maybe the facility struggled with this. But this was him for many years, just on a Dexcom and that MDI regimen, and even with trying to fine tune that regimen over and over. Finally, last year, we put him on the iLet Bionic Pancreas. So this is, again, the one where you don't have to carb count. You just say, I'm eating. And this has been his control consistently over the last year since being on the Bionic Pancreas. And he is still eating purely junk food. So it's really learned him and able to optimize this control. And the last 2 appointments, he has not needed an eye exam, which I think is really awesome. And maybe one of the other really cool parts of this is we got his entire nursing facility staff, which I think was 17 or 20 nurses, to sit in on 2 separate 2-hour training sessions with the iLet reps. So everyone knows how to work these systems. They know how to change the sites. And I just saw his mom last week and him, and so this has been absolutely life-changing, and his facility is very excited as well. So maybe taking a risk on some of these patients to really help improve their lives. So my conclusion is diabetes tech is really cool. These systems are becoming more sophisticated at a very rapid rate. CGM should and can be integrated at primary care visits, but if patients want to use a pump, send them to us. And we should just all be curious about what our patients are wearing and using, even outside of the endocrinology realm. Diabetes tech improves outcomes like we've talked about, but do require thoughtful and equitable integration. I did not really talk about this in the talk, but I did want to bring it up because it's important. Diabetes education is critical for all of this because different behaviors can undermine all of these algorithms and the effectiveness of the pump. So making sure our patients are routinely seeing diabetes education as well. And we all need to advocate for equitable access for these systems and continued research. So Dr. Semenkovich gave a great talk a couple weeks ago and ended with this quote, and I really love it. It speaks to me a lot that we do the best until we know better. When we know better, we should do better. And then a thank you to Dr. McGill as well, who's been just a great mentor as I try to become a good diabetologist. And we're actually heading to Amsterdam in a couple of months to do the International Tech Conference, where this will probably all be outdated by then. So thank you.
Thank you so much. I'm sure we have time for a couple questions. We got a lot of endocrinologists here who probably have some questions too. So I'll start. So, you outlined the health disparities and the challenges. What do you think would be the biggest sort of first step in trying to reduce those disparities? And are there any opportunities here in our system to really track disparities and then start targeted interventions?
So that's what I was thinking. I know Kai Jones is kind of invested in this as well. Oh, sure, you're right. You're invested in this as well. So I think one thing that could be really doable, and I've been thinking about as I put this talk together, is figuring out how to track an epic. Because if we can figure out who's had at least the education, who we've talked with patients about, we can identify these more easy. And then, maybe not even ask the same patient over and over and they keep saying, no, we don't want tech, but at least we know we've talked with patients. So I think that would be a great first step, is how to integrate this in Epic. Yes. Yes. Dr. McGill?
I think it's never mentioned as equity coaches.
Yeah.
Medicare, a CGM is 80/20, and Advantage programs are better. The pumps can be $12,000 at 80/20. Can be really daunting for patients. The problem is we don't know what the copays are. And that ends up being this underpinning of difficulty. And I don't know how to
Advocating policymakers and insurance companies.
Can you just repeat the question for the audience?
Oh,
'Cause we
so
can't-
the challenge is copays. So even for people who do have insurance coverage, maybe it's like 80-20. So let's say they still owe 20%. A pump can be many thousands of dollars. So even if they technically have insurance coverage, that out-of-pocket cost can be quite expensive, even with their monthly supplies. They have to get infusion sets, reservoirs, the CGMs, insulin. So this is really a challenge even for people who have insurance coverage. And when we're prescribing these, we really don't know until the patient tells us. So I do think this is a challenge that I'm not sure how we fix, other than advocating insurance companies and policy.
Yeah, so maybe some opportunities with Karen Joint Maddox's policy group and the new School of Public Health and direct partnerships with advocacy with insurance companies showing outcomes and,
Yeah.
and potential benefits might be an opportunity.
Absolutely.
Other questions?
Yes. So the question is, if we put people on hybrid closed loops who have very high A1Cs, are we seeing any increase in, you said neuropathy? Treatment neuropathy. I have not personally seen that. I think one thing we kind of are on the watch for is worsening retinopathy. There are some data that quick control, kind of changing the fluid shifts, can worsen retinopathy. So I do think we practice trying to, like you mentioned, slowly go down. Sometimes with the systems, it's really hard because, you know, we put in the settings, but it's going to tighten things up as it once. I actually haven't seen that in my practice. I don't know if others have, but it's something that we are aware of, but I just haven't really seen that in clinical practice.
Kelley, thank you so much.
Thank you.